We'll get started. So yeah, hello everyone, good morning, good afternoon. Just a quick welcome to our third seminar in our monthly series. And today we've got a session dedicated to the Commonwealth Pharmacists Association, CPA, and their fellowship programme, which will talk a little bit about the Commonwealth Partnerships for Antimicrobial Stewardship, the CWPAMs, and then also their experience on tackling AMR. So just before we get into it, I just want to remind everyone that if you have any questions, we will be answering them at the end of the presentations. And if you could use the Q&A function at the top, that'd be great. But if there's any issues, feel free to put them in the chat. And I think then we're good to start with Beth, who's going to lead it. So Beth Ward is the strategic lead for workforce capability building at the Commonwealth Pharmacists Association, where she leads the design of international programs focused on health system strengthening, workforce development, leadership, and antimicrobial stewardship. In 2025, she led the development and launch of the CPA Academy, a global learning and empowerment hub designed to strengthen pharmacists' capability across the Commonwealth, particularly in the low and middle income countries. A pharmacist by background, Beth has over 20 years of experience across clinical practice, healthcare leadership, and global health. She also holds a global MBA in health and works closely with governments, professional bodies, and international partners to empower pharmacists to play a greater role in addressing health systems challenges and improving patient outcomes. So I'd like to welcome Beth to share the screen and begin the presentation. Thanks, Beth.
Thanks so much, Michael. And I'm also joined today by my colleagues, Max and Edna, who you can see on the screen. So welcome, everyone. It's great to be here this morning and to be able to talk to you a little bit more about Commonwealth Pharmacists Association and, importantly, the Commonwealth Partnerships for AMS. So, as we said, so I've got Max here, who is our head of programs at CPA, and Edna, who is one of our brilliant fellows, assistant director of pharmaceutical services from Kenya. Now, we just realized about 4 minutes ago that the sound on the video isn't working, so I'm going to skip through here, but it was basically an introduction to CPA. Essentially, in a nutshell, we were established back in the 60s. We're a UK registered charity. We are in official relations with the WHO, and we're an accredited organisation of the Commonwealth. And we work with the 56 national pharmacy associations across the Commonwealth to see how we can work together to improve access to medicines, improve the safe and effective use of medicines, and empowering pharmacists, all for the benefit of patients and the public. And we do this. We do this through three key strategic pillars of work. So we'll be talking a lot about the workforce capability building today, but really it's important to understand we do a lot around advocacy, but we're very much about an implementation organisation. So putting advocacy into action, making change happen. Same with policy, putting policy into practice. And that's really where our big program of Commonwealth Partnerships for Antimicrobial Stewardship sits. And within that big Commonwealth Partnerships program, the fellowship was born, and that sits within our workforce capability building pillar, or the CPA Academy, as Michael mentioned, which we launched just last year. So I'm going to hand over to Max to provide some information about this big anchoring program, which is the Commonwealth Partnerships for AMS.
Yes, thank you very much, Beth. Like Beth has said, the fellowship was born under the CWPAMS program. Like some of you may know, CWPAMS, which is Commonwealth Partnerships for Antimicrobial Stewardship, was run under a health partnership model where we had institutions in the UK do partner up with institutions in Africa, as you can see on the right-hand side of the picture there, to form a health partnership. So once the health partnership was formed, the institutions co-designed a program on antimicrobial resistance to tackle AMR in the African setting. So we ran across 8 countries, and the scope of work that we covered, these are areas where our fellows did a lot of leadership, and we saw a lot of results through the fellowship, the fellows leading these areas of work, which included MS, IPC, microbiology, community pharmacy, substandard and phosphide medicine, the fellowship itself, behavior change, the hub and spoke model, and then we had to engage policy and national stakeholders for the sake of sustainability after the program closing. Next slide, please. Yes, and more about the reach of this program, which also tells you how far our fellowship did go. We had 31 hospitals across Africa and UK implementing the program in the 8 African countries. And then we trained close to 35,000 healthcare professionals in MS and IPC. And then we did run over 200 AMR interventions, covering a scope of over 32,000 hospital beds across the 8 countries where we run the program. And then finally, about the context where the fellowship did run, we had 18 hubs. These were more of centers of excellence that were pushing on their expertise in antimicrobial resistance to inform or mentor other facilities that didn't have this experience using locally tested practices and interventions. And then we had 100 MS committees set up through this fellowship, through the program where, like I said, the fellowship was really key in getting these things done. And then we had 100 local AMR action plans implemented. We had 91 sites working with PPS data to ensure that interventions are conducted after the generation of the PPS data. And then we had 83 sites generate and share microbiology data. 75 of the sites did develop new and updated guidelines to support antimicrobial stewardship, but also IPC. And then we conducted 246-point prevalence surveys across the sites where we did work. And then finally, we had 40 antibiograms developed and informed prescribing practices. Thank you. Beth, you're muted.
Thanks, Max. So in terms of the fellowship itself, as I said, it sits within our workforce capability pillar, which is comprised of, you can see we have like CPD, workshops, webinars, the leadership fellowships, other clinical training pathways, and importantly, these learning experiences and mentorship. And I think that's something important that has been embedded into the fellowship, and we're continuing to build on that as time goes by. But everything that we do is aligned to global standards and mapped across. So for instance, the fellowship program was mapped across to the WHO AMR curriculum, also to the standards of advanced practice for pharmacy practice at a global level as well. So trying to anchor everything that we do in and align it with global standards, so the relevance and applicability can be seen by everybody. So the fellowship itself, you can see some of our graduation photos from the in-country celebrations, which were absolutely brilliant. So how did this come to be? So when the Commonwealth Partnerships program, it was all around having pharmacy-led teams, because we could see that pharmacists have a very important role in antimicrobial stewardship, but often don't get the opportunity to be at the table, so to speak, when decisions are being made or when projects are being undertaken. And so we did a scoping study prior to the launch of the fellowship and identified, obviously, I think everyone on this call knows that AMR is escalating globally, and this is why we're all here trying to do what we can to address this. But pharmacists are key AMS leaders, but there was a major deficit in leadership skills in terms of the training and opportunities. So a lot of people there obviously have leadership capability, but if they didn't get the opportunity to apply these skills or develop these skills, then it was missing a trick, really, where there could be key people within the healthcare workforce who could be supporting, advancing and leading on AMS programs. And so the other thing that was identified, that these opportunities, particularly in Africa, were very limited. So the core aims of the fellowship was really to focus on equipping mid-career pharmacists with health leadership skills, as well as AMS skills, as well as skills in quality improvement and behaviour change as well, to address this critical gap. And looking and seeing how we can support these pharmacists to be leading local initiatives. So as Max has described, and I'm sure very similar to the types of projects and programs that other fellows through the Fleming Fund were leading and delivering on. And supporting these local improvement, because this is all about sustainability. So, at the end of the program, where are our amazing fellows like Edna now, and how is that leadership being carried on to ensure that AMS is being addressed continually? And of course, growing a network of pharmacy leaders, but we're here today to be connecting everybody into this wider pool of AMS champions. And it doesn't really matter what profession you sit in, if our whole vision is around tackling AMR and AMS through AMS, then I think it's a good thing for us to all be connecting together. So the fellowship itself evolved. So it started out where there was, within the partnerships program, as Max shared earlier, it was a partnership between UK institutions and African institutions. And the first fellowship was launched with the UK cohort because it aligned with an existing fellowship program in the UK. And those pharmacists went and had placements in Africa as part of their fellowship program. Learning from that, though, it was like, why are we training the UK pharmacists with leadership skills and not providing the same opportunity for those colleagues in the African context? So then we created the African Leadership Fellowship in AMS. And then the third evolution was the most recent cohort, where it was bringing together the UK and the African fellows to be learning, training and leading together. And so that was the cohort that just graduated earlier this year. So the fellowship itself was 12 months long. As I said, it was very much focused on developing health leadership skills, as well as training in AMS, quality improvement, behaviour change. It was a blended learning program, but a key feature of this was around the mentorship aspect. So each fellow had 2 mentors, one in country and one cross country, to support the development. And through this, we had the evolution and development of the alumni mentoring program. So in the last cohort of fellows that we had, this was a program that was supporting those who'd been through the fellowship to develop their mentoring skills, to then be able to have them supporting the new cohort of fellows that was coming through. And that's something that we're continuing to build on today, and connecting into this network as well is a brilliant opportunity for everyone to be able to develop those skills further. So as I said, the alumni program really built on this dual mentorship model that was embedded within the fellowship itself. And it provided structured mentoring support to the alumni fellows. So training in how to be a mentor, as previously they'd been a mentee in this system. So looking at it from the other side, what does that mean and how does that work? And I think actually having been a mentee is a very useful experience to then becoming a mentor, because you know yourself what works, what's useful, and what also people might be not forthwith coming, speaking up about what they need from the relationship. And so a key purpose of this is just to be continuing to reinforce the connection and the mentorship and the community of AMS champions. So in total, in the latest programs, we've had 113 mentors, and you can see 31 of those have been alumni mentors, and then 82 have been other global health and AMS experts. Some of you on the call may have even been some of the mentors supporting the fellows through the latest round of the fellowship. So if you are online, thank you very much for your support and your input. And my last slide here before we get to the amazing Edna, who can actually speak about the fellowship from a first-hand experience. But overall, the impact, so we've just been finishing the evaluation of the Alpha and the UK Alpha Fellowship Programme. And what we have seen is a demonstrable improvement in AMS practices through training and awareness. We've seen fellows stepping into leadership roles, fellows moving into positions within ministries of health, within other key areas, to be championing AMS at a government and ministry level, which is absolutely brilliant. We've seen measurable increase in confidence and capability to lead in multidisciplinary AMS initiatives. And this has led to increased capacity building for AMS policy development, institutional recognition, so importantly having AMS and funding for AMS activities being embedded into local budgets and into national budgets, which is absolutely what is needed to continue to build the sustainability of AMS principles and activities into action plans. and overall strengthening leadership aspiration, because people can relate to other people that they see. They're like, I know that looks like someone that could be me. So how can I step into this space and learn and be inspired? But I'm going to stop talking, because what we're really here today to hear from is our colleague Edna, who is a former fellow, one of our alumni, but a brilliant leader. And I'm going to hand over to you, Edna. So I will just let me know when you want me to move your slides on.
Okay. Thank you, everyone. Thank you, Beth. Thank you for our walk through the fellowship. Actually, I can confirm that quite a number of us picked up leadership positions, including myself. I was able to be a regional county AMR focal point through the fellowship. The fellowship started between 2023 to 2025. So in my opinion, it's one of the best thing that happened in my career. And so let me keep the ball rolling on the project that we took. In the partnership, we looked at the aspect of One Health, where we look at AMR in the aspect of animal health, human health, and how it makes its way to the environment, then come back to the human health aspect of it. And so we did an impact of antimicrobial stewardship, behavior modification, intervention on One Health among the Northern Kenyan pastoralist communities. Next slide, please. So as I was saying earlier, One Health seeks to implement a new paradigm in which the approach is balanced, whereby we look at ecosystems, people and animals. AMR is a global concern now. Even studies have shown that there is high levels of fatalities, approximately 5 million. From the region we did the project, it's Northern Kenya, where there's a harness relationship. Pastoralists are local communities that deal with animals a lot, but of course also using their own human health antibiotics. And how do they dispose? So holistically, One Health is very well practiced here. And the use of understanding the use of antibiotics from the three aspects of One Health is very important and very essential. So the objective of our project, I could say, if you're a researcher, you'd call it a quasi experiment, where we assess the knowledge, attitude, beliefs, and practices of antimicrobial use in the pastoralist communities before and after behavioral interventions. As I said, the target population, if you can look at the Kenyan map, the northern side is consistent of Laikipia County, Isiolo and Meru, among other counties. And so it was a utilized mixed method approach where we did semi-structured questionnaires and focused group discussions. And the study design was evaluated using a pre and post-intervention framework. So what we did a focus group discussion among the communities to truly understand what issues do they face through the use of antibiotics, both to animal health and human health, and even how do they dispose? How do they attain these antibiotics from the markets or the pharmacies and the agrovets? Agrovets are some form of pharmacies for animals. And then truly understand, do they too understand what is AMR? And then we did an intervention, which we're going to see later, and then did the exact post-focus group discussion to see, did we have any impact to this community? And they say pictures speak 1,000 words. So those are the pictures from the pastoralist. Of course, we had approvals from them. And you can see the team delivering and also doing focus group discussions. So it's important to know from the fellowship, and all of you can agree with me, when you're doing a behavior intervention, it is very, very key that you do not impose, but you try and adapt from the culture so that you can have an acceptance and also championing of the aspect that you're trying to introduce in the community. So one may ask, how are we able to be accepted, and how was the concept of AMR being accepted in the communities? Is that we identified the voice of the community. And these are female elders who also are known to be traditional birth attendants. And then also one of the biggest wins that I think we were able to do, we had community health volunteers also who were put in as trainers of trainers. What community health volunteers also do, they do trainings on other aspects like tuberculosis and malaria. So they are very versant with the community. And so we were able to integrate AMR modules and AMS modules and IPC modules in them. And then when we did a very vibrant, almost 2 weeks training to the female elders and the community health volunteers, we were able now to do a bigger training for the pastoralist communities. Also, as I said earlier, for behavior modification, it's very important to make sure that there's adaptability of the principle that you're trying to introduce to the community. So what we did, it's very, very important that we tried to translate our educations and job aids into local dialects so that there is enough understanding in the community. And then one of the also very big achievements that we saw, it's a low-hanging fruit, but very impactful, is that we were able also to do a recording of a song and One Health AMR song, of course, in local dialect, and again, also produced by the female elders themselves. And this song actually carries snippets of information about AMR and AMS and IPC. And one thing also that has been a very big win is this song till now, it's been played in political rallies, in religious organization. So you see, we keep on carrying on the AMR song still even after the project is over and the fellowship is over. And it gives even the female elders an opportunity to continue carrying on their songs. Also, before we move to the next slide, it's also very important to say that it's, again, a multidisciplinary approach. We had a veterinary doctor on board, and we also had an environmentalist on board. We would be happy if you listen to the song as well. So what we did, we were able to do first the 51 pastoralists during the pre-survey. And it's also very important to see that there was a lot of interest. Everyone was now quite interested to know what is AMS, AMR, and IPC. And for the post, we were able to have 104. And quite unfortunate to know that only few participants in the pre-survey noted giving and stopping antibiotics according to the vet prescription and following the instructions on the bottle. And however, from the post-survey, most farmers acknowledged that AMS, through the AMS guardians, they could subsequently and frequently call the vet before use of antibiotics to their animals. The next theme from the focus group discussion is procurement and advice. One thing that is very standing out in AMS, AMR, and all of us can agree, our biggest stakeholder in this is the public or the people that we serve as health providers, is when you give them the power of the knowledge, they're able to know what are they supposed to do when they are accessing antibiotics. It's quite unfortunate to know that initially someone would go to the market, open a car, and start selling animal medicine, human medicine. However, we were able to empower the community with the knowledge. And that's what we were saying, they used to get it informally from open air markets. However, after the post-survey, it's very important to say, and it was quite a big win, that most of them would go to licensed, approved agrovets. Agrovets are more of the pharmacy for the animal health. And also from the human health of it, they would make sure that they go to hospitals, get a diagnosis, and see a qualified pharmacist and a qualified medical practitioner before accessing an antibiotic. A number of farmers also, again, by empowering the AMS guardians, who are the traditional birth attendants, and the community health volunteers, most of them would be consulting them prior to using antibiotics in the post-survey. And there was also a very significant increase of AMR knowledge about AMR and what it entails, IPC, infectious prevention and control, and AMS among the 5 communities in the post-survey. So the next theme is the use of animal produce in administration. if we can have a vet in the podium, in the platform, they can agree with me that the drug usually has an alert that please make sure that you take maybe 72 hours before consuming animal produce. But unfortunately, pre-survey, most farmers didn't used to follow this. Most pastoralists didn't follow this, the consumption of animal products. However, they almost used to do it immediately. And one participant said they consume the meat actually on the same day, even if the animal died. And others stated that they would consume the animal product on the same day, but actually not sell it. But it's very important to know that it's quite unfortunate, because if you take a milk that has been maybe given a tetracycline, of an animal that has been given an oxytetracycline, of course, it makes its way to the human body. And so that's already a drive of irrational use of antibiotics. Next slide. So in the immediate consumption of animal and dairy use following administration of antibiotics was highly noted and very significant. Also, it's also very important to say that sometimes they would even give antibiotics to animals for prophylaxis, which of course it's not a good way because they're not qualified, and there's a lot of antibiotic use in animal health, and that's how it makes our way to human health because of the consumption of the use of antibiotics of the animal produce to humans. Next slide. So the biggest animal in the room, which is AMR, in the baseline, some participants noticed adamycin, which is an oxytetracycline, which is also the same as tetracycline in human health, was used to mix milk, and it was done by mixing it with milk. And also, as I was saying, the pastoralist community, they do a lot of travels to the fields. And so some also, they could say, if they would get a cat during the travel to the fields, they would use animals' antibiotics on themselves, which is it was quite shocking to learn. But the antibiotics are actually, as a pharmacist, I was very entertained to know that the antibiotics that veterinarians use are the same antibiotics that human health use, just that it's on higher doses because it's an animal produce. And most of them would tell you that it would actually work, but we were able to convince them and train them that animals' antibiotics should be used by animals, and human antibiotics should strictly be used for animals, for human. And also, as I said earlier, there was a lot of prophylaxis used on chicken, especially, whereby they would give antibiotics to chicken, human antibiotics like amoxicillin, as a form of prophylaxis. So the knowledge of AMR was limited to many participants, and they had not had AMR before. And most of them usually would, there was a lot of mixture of misunderstanding of AMR and simply treatment failure. This was very keen for us because a lot of work has been done on tuberculosis, on what is treatment of what is treatment failure in TB and AMR. And so the community health volunteers came in handy to be able to train on what is AMR and what is treatment failure. However, one participant did say certain antibiotics were no longer effective, and sometimes drugs do not cure animals as before. So they had already had an observation that we are headed to a period where antibiotics are no longer effective, but now they were able to understand exactly in very simplified local dialect information on what exactly is AMR, IPC, and AMS, and what is their responsibility to make sure that this is addressed in their communities. So graphically, you've seen awareness of AMR. The blue bar shows pre and post. So even in a particular community, none of them knew what in Manyangalo, you can see even none of them knew what AMR is at all. And it was a proud moment to see that 81% of the pastoralists were able to understand what AMR is. And again, it's through public health campaigns and in humans that some had an idea of what it is. And that's why, again, I say, I think it would have been a very good thing if we are able to see through other public health concerns, how can we install AMS, AMR and IPC in other aspects of public health so that we make sure that the information gets to everyone. So remarkably, in the post-survey, the knowledge of AMR was significantly increased across all of the 5 communities in the northern part of Kenya. So we thought as a team that it's very important to pick testimonials from everyone who was in the training. It was a proud moment to note that the female elders in Garindari, which was one of the community, has been very helpful. That is something she still calls me till today to confirm with me. And I still insist, please take your child to have a qualified practitioner, make sure that they get the right diagnosis. Please make sure that when you're going to buy drugs, buy it from a qualified personnel. Again, we were very proud to know that they are waiting for at least 72 hours before having the animal products consumption. We were able also to compose a song on hand washing. Hand washing is very key in IPC. And so they are able to remember and continue making sure that good IPC practices are improved. And also, it's very proud to know that they're no longer buying from open air markets vendors like they used to do. And as we are addressing AMR, we are also trying to make sure that falsified medicine and substandard medicine is also addressed to the public. So this research has highlighted key components for discussion. And in short, there's a significant knowledge gap. So this shows that we have quite a lot of work to give knowledge to the public on what roles do they play on AMS and AMR and IPC. And if replicated, this directly contributes to AMR as a global threat, and that will have a consequences of human animal health and planetary health. So use of antibiotics to promote growth in animals has directly increased the risk of AMR. There are also other papers that are agreeing to this. Antibiotics, unfortunately, here in Africa and northern Kenya, which is part of Africa, it's being used to promote growth, which came out during the first focus group discussion. And also there's also direct, this goes to direct link because the same animals they're the ones which are brought to the market for consumption. And then there is also a review from isolates from the bacteria in Isiolo region from another study have shown that the cattle herds where antibiotic use is widespread already have multi-drug resistant to Staphylococcus aureus in raw milk. Raw milk is still widespread, particularly in pastoralist communities, and therefore could lead to infectious diseases, resistant infectious disease to human health, because if I'm able to take milk from a cattle that already has AMR, that means I already expose myself to AMR through consumption. Behavioral modifications such as veterinary guidance on husbandry, biosecurity is how they do the disposal in animal health, and antimicrobial use, educational programs, giving feedback has shown to be very effective. Clearly, you can see from our context, there was a lot of improving knowledge, testimonials that now they double check with female elders, testimonials that now people are avoiding. If we can able to empower 100 pastoralists to know that please don't go to a merchant in the market who has a car and opens to sell you antibiotics, then we are actually having significant impact to our communities. What could we recommend from the study is that cost-effective behavioral change intervention, such as capacity building, use of voice of truth, community champions, people who are the voice for the communities, are effective to and meaningful change among pastoralist communities in low and middle income countries. Beth and Max can agree with me. We had an arm of the fellowship through the Edward Jenner program that showed, as a leader, what aspects can you bring to people to make change, and how can you improve and make adaptability? How can you even form teams around you through everyone's strength so that you can have an effective outcome? And if there's one thing that really helped us in here is the aspect of behavior change. You see, if you can have a leader adapting or accepting your concept, then there's also a very high probability that the people following that leader will actually adapt. Again, if it's an aspect of behavior change, by all means, please try to see how can you adapt yourself to the community or to the health workers or to that particular ward or to that particular hospital, so that you can have a more form of acceptance from them. Adaptation to culture is key. That is one thing I think that has really stood out to me. Low-hanging intervention. Globally, we've seen a very significant change in terms of funding. And so when we are doing the fellowship and when we were doing the projects, there was a lot of, can you have impactful, but also aspects that don't need a lot of funding. And so having something like a song that even after the funders or after the fellowship is over, that people can still have a reference to. Job aids, we had a lot of job aids that we were able to stick in their rooms, in the churches, and in local dialect. So to reflect on this, coming together is a beginning, keeping together is progress, working together is definitely a success. And the ends of the fellowship, the ends of funding is not a bad thing. They just mean something else is about to begin. Thank you very much.
Thank you so much, Edna, for that. And as I said, it's much better to hear from the source than us talking about a program from a more theoretical concept. Thank you so much. And yeah, just to finish from us, because I know we're short on time, is that what's next for us is that how can we keep the conversation going? So we're establishing a Pan-Commonwealth mentoring program at the moment, and in quite advanced discussions around how we can continue the fellowship in some of the African countries. But yeah, thank you very much. But a huge thank you, Edna, because that was absolutely brilliant. And the one song, please download it and listen to it. It's fantastic. And I'll hand back to you, Michael.
Thanks, Beth. Yeah, thanks, Max. Thanks, Edna. Yeah, really great presentation. I say it's really nice seeing them kind of real life experiences and opportunities you get through fellowships. So, yeah, it's always lovely to see, and we'll be definitely listening to the song after this. So, with the end of the presentation now, I'm not too sure. Did anyone have any questions to ask? We can use the Q&A function or the chat function. So I might kickstart off and see if anyone wants to ask questions afterwards. I did have one question for Edna. So since you completed your fellowship, what would you say the biggest skill is that you took from your fellowship that you now use in your current role at the county government? Is there kind of one in particular?
Yes, there's a lot of things that I picked up, but one is the aspect of stakeholder mapping. It was very entertaining to know how can you identify someone within the stakeholder that will have an impact, which leader, how do you lobby? And through that, we were able to see through our action plan, it was able to be adapted in the work plan of the bigger county. And so AMR is able to be given funding from the budget of the hospital, the health budget. And that's a very big win, because initially AMR, IPC used to take a seat back, but now it's being addressed, like just as procurement of medicines, hiring of staff, HR. So when we are doing our budgetary allocations, we are able now to see that we get also funding, which is actually very sustainable. It's not, of course, a lot of money, but we are able to continue having the running of AMS committees. So yes, stakeholder mapping is to see how can I approach the big guy on the top and see that to show that AMR is important and it needs to be funded and being added in the annual work plan of the counties. Thank you.
Amazing, thank you. Yeah, did anyone else have any other questions? I can't see any in the Q&A at the moment, so I can ask one more, which I think might be split between Beth and Max. So I was just wondering, from the kind of mentee to mentor point of view, is there a tip or a piece of advice you might want to give everyone on the call today, who's kind of maybe looking to move into that, kind of moving from a mentee to a mentor? Yeah, if there's a piece of advice or any support.
Yeah, I think just from listening to, because we're in the middle of doing the scoping right now about the mentoring program, and that has been speaking with people who've been on both sides. And I think for being a mentee, don't be fearful about becoming the mentor. I think it's not always about hierarchy is definitely not necessarily what needs to be considered when thinking about mentors. And as someone who's new to mentoring, you've got a lot to give. It's not just people who you see as being perhaps more advanced than you are, because a lot of the time your perspective is so important. And having been the mentee is really important, because some of the feedback that we've had, and you've probably had it yourselves, is when you're first a mentee, understanding what the expectations are and how that relationship works, even being able to help people navigate that process is incredibly valuable. So just to go for it. And there's support out there, and that's why we're developing the Commonwealth mentoring program, and that is like looking at how can people support others within country, and not necessarily just like pharmacists. This is like people within the health community, within country, across countries, but there is support out there available for you. So, go for it is all I could say.
Yeah, maybe just to build on that a little is how we at the Commonwealth Pharmacists Association, we are leveraging the presence of technology, that mentorship doesn't have to be limited within someone's country, that we can have someone in Uganda, someone in Kenya being mentored by someone in the UK, and then someone in the UK being mentored by someone in Uganda or Kenya. So that bi-directional learning, I felt like it was a very key aspect of our mentorship program, in that it allows for sharing within the global health. Yeah.
Brilliant. Thank you both. Yeah, and obviously I'm sure the message will be passed around once your mentor opportunities are ready. So yeah, that was really good to hear. So it looks like we've got no more questions for today. So I think I'll just finish now by thanking again Beth, Max, Edna for the presentation this morning. It should be able to be available online, hopefully by the end of the day, if not tomorrow, on the Fleming Initiative webpage. But we'll communicate that out with the recording afterwards. So I think I'll close the seminar now. Thanks to everyone who joined this morning. We hope to see you again very soon. Have a nice day, everyone.
Thank you very much.
Thank you.